All right, it's not so bright and early here in San Francisco, but very, very excited for today's VMR. Before I tell you the case presenter and the case discussant, I'd love to give some love to the people who make this happen. The first is Julia, who's doing our scribing today. Julia, want to say hi?
Sure, hello everyone. I'm the lucky guy who is not having to get up very early in the morning, so it's Friday afternoon and very sunny here in Germany.
Amazing. Yeah, Julia, I wake up pretty early, so this is actually the middle of my day. The sun is slow today, but it's okay. Um, Also rising very early in the Bay Area is Sohail, who's doing our teaching points today.
Good morning, everyone. I have my morning coffee here. I have to say, I only drink coffee for these sessions because they're just too early. I don't typically drink coffee, but good morning, you all. Very nice to see you.
Very nice to see you too, Sohail. I learned recently that coffee ain't so bad for you, especially if you drink a whopping amount of it. So I think VMR is nourishing you beyond just the educational value, I hope. But speaking of nourishing in VMR, you guys should know that the case discussant today, Deborah, um, has made VMR what it is today. So there was a time when VMR was cachectic, to say the least. Um, See, I got to use my fancy word of the day. And then Deborah, who you see here, was part of a duet or a trifecta of people who really resuscitated VMR and really have gradually but slowly turned it into what it is now. And for that, I think all of us should be forever grateful for what Deborah has done. And recently, she, along with Noah, has made it all the way to the stratosphere of the podcast. And I think within CP Solvers, that's really the peak. It doesn't get much more intense than that because it really symbolizes just how organized you have to be, how thoughtful you have to be to put on a polished product that is consumed by tens of thousands of people. And so today is no big deal for Deborah. She already had her papers ready, stacked them up like the CEO she is. Um, I'll pass the mic to you to say hello, Deborah, before we introduce our case presenter.
Hi everyone, I'm really excited to be here. It's been a long journey on TPS solvers. We work a lot. When I started, we don't even have the academy, so it's really good to see how much we grow. And I work a lot in the background, so sometimes people don't see me, but everything there's a little bit of my advice or something that I put. Some people call me a little bossy, maybe I am. And I'm happy to discuss with Rabih. He's a really nice person, a friend, a mentor. Sometimes he calls me and I can start crying and say when life is not going well. So I'm really happy to have him.
I appreciate your kind words about me, but I know your best friend is Dr. Jas Bajwa, who we have to we have to honorary mention. And for those of you who are part of the academy, just look at the chat, and I think that'll that'll answer every question you have. Um, but long overdue. Would love to welcome our first time guest presenter, Ryan. Ryan, tell us a little bit about yourself, please.
Well, thank you so much for having me. I'm at George Washington University Hospital. I actually just finished my residency in June, so now I'm actually the chief resident here in charge of education. So I'm a big fan of the podcast, and I've been to a few of the morning reports as well. So I'm really excited to present a case here.
All right, that is so cool. Wonderful. Congrats on graduating residency and slotting into
Thank
that.
you.
Well, that is a huge, huge honor. Where do you call home?
So I'm from Buffalo, New
I
York,
see.
originally.
Yeah.
Yeah, so this is down south for me.
Mm-hmm. Do you miss the snow?
Um, I maybe a little bit. I do like to ski, so I think
Yeah, I see.
for the 1 week of the year where I would actually ski, I miss that. But I'll tell you, it's a lot better weather in the mid-Atlantic.
I completely agree. Yeah, one of the reasons one of my roommates in college in Boston was from Buffalo, and one of my closest friends, and I'm happy to escape the snow to San Francisco. And I never got to ski, so I don't miss it too much, to be honest with you. Where do you see yourself next year? What are you hoping to do?
So I really like hospital medicine, so I'm hoping to stay with that and do both hospital medicine and stay within academics as well. So I hope I can do that.
Amazing. You're a good company. Andrew here, Mark is here. Both are hospitalists who love medicine, and I imagine share your joy as well. Well, all right. Well, without further ado, I think Julia can share the screen and we can rock and roll, Ryan.
Awesome. So I'll say first, this is about one of the last patients I admitted as a resident. So this was a special patient for me. But I'll start with the first aliquot, which is a 26-year-old female who is presenting to the emergency department with 2 weeks of postprandial pain. The patient was previously in her usual state of health until she began having a significant epigastric pain after meals that was worse with solid foods. The pain is stabbing in nature and radiates to her back. She has been able to take in some fluids despite limited PO intake otherwise. And that's the end of the first aliquot.
Well, thank you so much, Ryan. I don't know if it's something on my end, but for some reason the screen isn't showing well. Is that the same for you, Deborah, or is that me? Oh, now it is. I don't know what just happened there. Okay, cool. Thank you so much, Ryan. I think I see it well now. So, Deborah, I'm curious, what thoughts are crossing your mind with this information?
Yeah, thank you, Ryan, for this aliquot. So it's a really young female, so I was wondering about this pain and like postprandial, like I don't know about the localization, but made me think about the mesenteric artery when it's chronic and could be a syndrome like which is ischemic, or like being epigastric, like make me think like a something the pancreas too. It could be like a gastritis, but I don't think it was like a pancreatitis. Sorry, I don't think she would be able to wait if it was like something like that for 2 weeks. And I would like to know about the food actually that she's taking. Maybe celiac disease can cause anything and everything. So I always think about that. And we need to like, of course, we use the mnemonic VIPO to exclude really like causes that can take like that can make the patient feel really bad, like vascular, ischemic, by obstruction and this
Perforation.
perforation. Thank you. Sorry.
Yeah.
And perforation. So definitely think about that. We when is a woman, we try to exclude you, like if it could be like a ectopic in pregnancy, but I don't think the pain would be so up. But just saying like for because it's the mnemonic. And sorry, my thoughts was a little lost. I was trying to grab everything that I was thinking at the same time. But yeah, I was thinking actually about SMA syndrome more and investigate more about the food, what type of food is making her feel worse. And
Yeah, you pulled on two things that I think were generating your thoughts. First, you were using postprandial, and that got you some thoughts. And then you were like, wait, let me make sure I think about abdominal pain. So I think you first went focused, and then you said, wait, it's very soon. Let me use broad. And I'm sure that's why your thoughts felt scattered. But actually, that's probably what people would be thinking in real life. They would be like, oh, wow, it's postprandial. What are those? But wait, let me be careful. And I think those were the two aspects of your case. Sometimes we're thinking a step ahead, Deborah. So I want you to either actually or literally close your eyes. And I want you to ask, when you see this patient in real life, do you think she will be in pain when you see her, or will she not be in pain when you actually see her?
I think she will be in pain.
Yeah. But why? Why do you think that? What makes you think she'll be in pain?
Because she's having for 2 weeks, so I think it's something that she is having
Yeah.
for a long time, and for her to look for
Yeah.
emergency room, probably she's in pain.
That's going to be the interesting part, Deborah, because I'm not sure. And I think by Ryan telling us that she is only having postprandial pain, that means that she is only in pain after she eats.
Mm-hmm.
And so the most interesting thing, the most informative aspect will be, is her pain strictly, exclusively postprandial, or is it not? Because if it's just postprandial, it cannot be an ectopic pregnancy. It cannot be acute ischemia. So what I'm most interested in is to see what she is like when she is sitting right here in the emergency room, presumably not having have eaten. Because if she truly is what we have heard so far, which is that it is just postprandial, that means we have to explain two things. We have to explain why she has pain after she eats. And then we also have to explain why the pain goes away when she doesn't eat. So perforation, it's not going to go away. Acute mesenteric ischemia is not going to go away. So it's very helpful to graph the patient's symptoms. And if we're doing this up and down, up and down, up and down, is very different than this. And what's really interesting, Deborah, is the VIPO mnemonic is for this, not this. So if she is not in pain when you see her and she is doing this, what do you think then? What could make it come and go?
Maybe like what she's saying about the food that she has been
Yeah.
eating, or
It could be because of the specific food she's eating, for sure. What do you think might come and go in the abdomen? Come and go, come and go.
good question.
That's the question. If you don't have any reflex thoughts now, keep that in your mind, and then maybe you get more medical history. So you start to say, oh, maybe that, maybe that, maybe that, maybe that. So, for example, if you hear that she has a lot of NSAIDs, what thoughts might cross your mind with
A
that?
lot of,
And ibuprofen, non-steroidal.
oh, that could be like if she had the peptic ulcer
Yeah,
disease,
that,
and
yeah,
that
exactly.
can cause.
Yeah, if the ulcer is there, she's not eating, no problem. When she puts food on the ulcer, ouch. When the food goes away, no problem. What if you hear that she is on oral contraceptives and is overweight, and the pain is actually a little bit on the right side?
And that I would think more about the pee.
Yeah, she might have. If she has, if her pain is postprandial and it's a little bit in the right upper quadrant, you might think she has biliary colic or gallstones. So I think it's going to be really interesting to see, one, is it truly just with food and goes away, or is it constant? And I think there might be other clues to help us figure it out. There's another clue about her it radiating to the back, which is very weird. What do you think of when you think there's pain that's going to the back?
I think a little more about the pancreas when the
Yeah.
pancreatitis like kind of radiate to the back.
Yeah, same. That's probably the most strong association is of all the things, the stomach, the gallbladder. I think the pancreas is the most likely to radiate to the back for sure. Really good thought. So to summarize, I think the key question now is she having continuous abdominal pain that's worse with food? Or is she having no abdominal pain and her pain is exclusively with food? That's going to be really key. If it's exclusively with food, it means that she is not having a good GI stress test. So it's all about what parts of the GI tract participate to digest the food: the stomach, the duodenum, the gallbladder, the pancreas, and the blood vessels. Those are probably the most important things to think about. But I think we have to be careful. She might be in pain continuously. And so that will change everything. And then we have to go to VIPO first. All right, Ryan, why don't you tell us a little bit more?
All right, absolutely. So, for the next aliquot, started off with some review of systems for her. She's having decreased bowel movements, but she's not having diarrhea. She's not having melena, hematochezia, or anything else that would signify a GI bleed. She denies fevers, chills, weight loss, or night sweats, and her review of systems is otherwise unremarkable. Some notable history for her. She had actually presented to an urgent care earlier in the week, and she was started on pantoprazole, which she has been taking daily without relief. At that visit, she had a urea breath test done for H. pylori, which she had just learned today on the day of presentation to the emergency department. That was positive. So she has not yet been started on any treatment for the H. pylori. In regards to her history, she does not have any previous medical diagnoses. On her family history, we learned that she has a history of CLL in both her dad and paternal grandmother, who were both diagnosed in their 50s. On social history, she smokes marijuana occasionally. She rarely drinks alcohol. She works an office job here in Washington, D.C. She did travel to Central America about a year ago to visit friends, and then she traveled to Europe about 2 months ago. And she doesn't have any allergies. When she first presented to the emergency department, her vitals showed that she had a blood pressure of 121/82, and she was tachycardic to 127, which resolved with fluids. And that's the end of the second aliquot.
Oh my gosh, Deborah, the story gets more and more interesting. What thoughts cross your mind here?
Yeah, like I think we got some really good information. And the patient start with the pantoprazole, I think they were thinking about peptide ulcer disease, but it's not improving. So definitely that would be a red flag. And the patient had like some trips that she did recently. So we always think about some infection that could be causing her all these symptoms. I would have definitely an eye on that. And we had like, oh, she smokes marijuana. I think we had once a case like that Yusuf presented about pancreatitis that was caused by marijuana. So that I remember too. Maybe have an eye on that. But yeah, at this point, I would start like trying to order some labs to investigate more what she has. What do you think?
Yeah, I completely agree with you. I was very, very intrigued about all the clues that we got here. And I think the most interesting one is to try to still figure out what is the problem. Is it continuous abdominal pain worsened by food, or is it no abdominal pain triggered by food? And if you see a heart rate of 122 and ask yourself, wow, why would somebody with only postprandial pain develop a heart rate of 122? That has me a little bit worried that she has something more sinister than just the causes associated with postprandial abdominal pain. In general, whenever somebody has a syndrome that is triggered by something, so chest pain with exertion, leg pain with exertion, abdominal pain with eating, there usually is no fingerprint of consequences when the trigger is not there. So you think about patients who have angina, when they just walk and they get chest pain, they stop. They shouldn't have sinus tachycardia at rest. When a patient who's saying she just has pain when she eats, I don't think she should have sinus tachycardia at rest when she's not eating. So I think that the presence of sinus tachycardia pushes us to be more cautious, just as you did initially. Initially, you said postprandial, then you were more cautious. And I think the presence of sinus tachycardia is not in keeping with a transient triggered syndrome by just eating alone. And so automatically, I am now more worried. I have never seen an uncomplicated peptic ulcer with sinus tachycardia. I have never seen biliary colic with sinus tachycardia. I have never seen transient pancreatic issues or pancreatic insufficiency with sinus tachycardia. So I'm more worried about this patient. And as you said, especially more worried since she didn't get better with some treatment, the pantoprazole. But Deborah, Ryan told us that her urea breath test was positive for H. pylori. What do you know about this test, and what did that make you think?
Like make me think that she could have like H. pylori, and the pantoprazole would not be enough. She would
Yeah.
have to have the triple. I don't know what's the recommendation now,
Yeah.
but we have the triple therapy or the
Yeah.
therapy with 4 medications. Maybe start treating that,
Yeah.
and yes, put a really nice pearl that could the H. pylori could be associated with mouth.
Yeah.
And
Def-
she has like some family history about
Yeah.
leukemia, so definitely like start thinking about that.
I agree. I think that whenever you have H. pylori, H. pylori it brings in H. pylori makes the story more complicated. The first association you can have with H. pylori is that in somebody who's sick who has H. pylori, you could definitely have H. pylori related cancers. There are actually 2 cancers associated with H. pylori. The most famous is the maltoma or lymphoma, but you also have a higher rate of GI adenocarcinoma in patients with uh, H. pylori. But most people with H. pylori have no symptoms. So this could just be a distractor. It could be that she has asymptomatic H. pylori and a separate cause of her syndrome. So that's what makes it very tricky. H. pylori is not like Staph aureus bacteremia, where 100% of patients are symptomatic. Some of us probably sitting here have H. pylori, have no idea we have it. So we have to be very careful and not assume this is driving the symptoms. And I like what you said. She could have H. pylori, but she doesn't necessarily have to. So I'll summarize. I think that the presence of sinus tachycardia is very unusual with a transient triggered syndrome. And as Deborah was initially broadening her scope, I'm now joining her and broadening my scope as well and being careful what this means. I'll also encourage all of you to be careful where the localization is, because as we talked about, we said postprandial pain is usually stomach, gallbladder, pancreas, and vasculature. The first reason to doubt that localization is the presence of sinus tachycardia. The second reason is that she is having decreased bowel movements. And decreased bowel movements are not associated with upper GI tract issues, for sure. It's also not necessarily just like the H. pylori a clue. Many people, when they're sick, they don't necessarily have to have good, healthy bowel movements. But it's a reminder that when we eat, Deborah, we have this thing called a gastrocolic reflex. And so some patients, when they have a pelvic problem, like an ovarian mass or a colonic mass, it hurts when they eat because they put food in their stomach, and then the gastrocolic reflex gets triggered and their colon moves as a result of that. It's also why some people unfortunately have to go to the bathroom to stool after they eat because they have an exaggerated gastrocolic reflex. So about 2 months ago, I had a patient with an ovarian mass who presented with postprandial abdominal pain. So the decreased bowel movements here, just like the H. pylori, is probably noise, but it opens the door to the possibility that she has a space-occupying process in her pelvis, very, very far from her epigastrium, and invoking the neuronal connection between the stomach and the GI tract. So I'd be careful with that too. All right, Ryan, you got Deborah in puzzle-solving mode. She's has her chin in her hand, very eager for your next aliquot. What do you have next?
I love it. So for aliquot 3, we'll get into the physical exam. And I'll say she hasn't eaten anything for hours now that she's in the ED. So generally she appears comfortable. She's well nourished, and she doesn't appear toxic. On HEENT, she has anictoric sclera. Her mucous membranes are dry, and she doesn't have any cervical or supraclavicular lymphadenopathy. On cardiac exam, she's tachycardic with a normal rhythm. She doesn't have any murmurs, and she does not have any lower extremity edema. Her pulmonary exam is normal. On her abdominal exam, her belly is soft and non-distended. She has mild tenderness in the epigastric region, though without rebound or guarding. And she has no masses or organomegaly. Otherwise, she has normal bulk and tone, no deformities, and no skin lesions as well. Her initial labs show that she has a white blood cell count of 9.23 with a neutrophil predominance. Her hemoglobin is 13.9. Her platelet count is 409. And her lights show that her sodium is 137. Her potassium is 4.4. Her BUN is 10. Her creatinine is 0.9. And her LFTs are all within normal limits. Her lipase comes back elevated at 3,754. Her lactate is 0.9. And then her UA is positive for 100 plus protein and trace ketones, but otherwise negative leukoesterase and no pyuria. And that's the end of the third aliquot.
All right, I'm so intrigued. What an incredible case. Deborah, you called it from maybe the second or third sentence. What are you thinking now?
I was not expecting this exam and labs, like, yeah, like I was thinking about if this tachycardia could be from the patient being dehydrated, like, so definitely like pass some fluids to see how is she gonna react. And yeah, this like lipase make me think like it could be something in the pancreas, like definitely like take an image to look how is the pancreas, if she could have like a pancreatitis. That could be caused maybe for the marijuana, maybe could be some autoimmune, even that the patient doesn't have like the main causes, that is alcohol, doesn't smoke or don't it did, or could be a gallstone too that could cause a pancreatitis, or it could be like if the patient has really high hypertriglyceridemia, which I don't think she has, but maybe we can start thinking about less common causes. Yeah, nothing. I think I would be worried about this patient. I always think like, is the patient sick or not sick? And this is a really young female, so I would definitely like have my eye on. What do you think?
The only word I would delete from your sentence is you said nothing after you said many good things. So I agree with you. I think that, when you have a lipase this high, the lipase can be rarely a false elevation in the context of two things, usually kidney injury and ketosis, the two Ks. None of them are here, really. She has mild ketones in her urine, but she has no ketones in her blood because her bicarb is normal. So the lipase is very likely a true positive, and it suggests pancreatic disease. Deborah, the only problem I'm having is I associate pancreatitis with not 2 weeks of symptoms. It's usually more aggressive, more abrupt, more acute, like few days, nausea, vomiting. So that's an interesting twist to this case, and that makes us question. That's an unusual aspect of this case that we have to at some point reconcile. But I love the way you were thinking about the causes of pancreatitis. You used the specific clues you have here, marijuana, and also the gallstones because of her postprandial pain. And I think in general, if you want to make the causes of pancreatitis very simple, they actually come down to one of two S's. Either there is a substance or there is a structural problem. That's it. The most common substance, alcohol. The most common structural problem, gallstones. Other substances, medications, calcium, triglycerides, marijuana. Other structural issues, pancreatic cancer, pancreatic cysts, IgG4 disease, pancreatic strictures. So the real question with pancreatitis is, can a radiologist see the cause, or can I pick it up on history? That's really it. So in this case, we have one substance, marijuana, but that substance causing pancreatitis is rare. And so that's why we have to keep that, but we keep that at the end. And so I think the conversation comes up about who deserves a CT scan for pancreatitis. So I'm curious, Deborah, what would you think? Do you think this person that you would recommend the CT scan, and what would be your explanation to the patient why she does or does not need the CT scan?
I would recommend a CT scan.
Yeah, and why? How would you explain it to the patient? Why do you think she needs it?
I would say, giving her situation and her presentation, maybe we could be thinking about some pancreatitis, and we need to take a look if it could be like something as a gallstone or something obstruction or structural
Yeah,
that could be causing.
yeah, I agree with you. I think there are instances where you can diagnose pancreatitis without a CT scan, and those when you have a classic presentation and a positive lipase. And in those instances, you don't need a CT scan to diagnose pancreatitis. And I think here, you don't need the CT scan to diagnose the pancreatitis because you have epigastric pain and a high lipase. But what you need the CT scan to do is to help you understand what the cause of the pancreatitis is and to make sure the patient hasn't suffered any consequences. So there are two reasons to get a CT scan: for diagnosis, and that's when you have atypical presentations. More often, we're getting the CT scan to help us understand the cause and to understand the consequences. And so here, the cause of her pancreatitis is not readily apparent at first glance. And so I would explain to her and say, as Deborah said, hey, marijuana is associated with pancreatitis, but unfortunately, it's a rare association. So to understand why you have this, we really need to dive deep and understand what's happening inside the pancreas. Also, unfortunately, you might have had this pancreatitis for some time. And as time passes, there are more and more chances of complications from pancreatitis, which are often something you would see on CT scan. So more for cause and consequence rather than diagnosis. And it'll be interesting to see, does she have acute pancreatitis or does she have acute on chronic pancreatitis? That'll be an interesting dimension, but I, like you, would also get a CT scan. The management of pancreatitis upfront is all about hydration and gradual introduction of diet and pain control. So I would probably keep her NPO. The principles of fluid management in pancreatitis have shifted dramatically. Before, we would just give patients fluids, as much fluid as possible. Now we have to be careful how much fluid we give them, and without going into details, aggressive fluid resuscitation in the first 24 hours is the standard of care, followed by backing off and minimizing fluid thereafter. So NPO, gradual reintroduction of diet, pain control, and aggressive hydration initially, followed by minimization after 24 hours. All right, Ryan, what do you have next for us?
So I have the CT that you requested for the next aliquot. Would it be okay if I actually shared my screen
Please.
for this one?
Yeah.
Let's see. So I have a CT abdomen pelvis here, and I can give the read in a second if everyone wanted to take a look first. And I think you should be seeing both the axial and then the coronal view.
Anything that jumps out to you, Deborah?
I'm looking, I'm trying to understand. I don't.
Yeah, it's hard.
What do we have like
Yeah.
in the stomach? Like,
Yeah. What jumps out to you about the stomach? You're right. I'm also looking at the stomach. What jumps out to you about the stomach?
I was thinking it could be
Hmm.
maybe cancer, maybe mouth.
Yeah.
Um,
What are you seeing though? What would you describe on the CT scan? Before you
I,
say what your DDX is, what is the abnormality you're seeing, you think?
I don't know if I can describe. I know that it's not normal, so
Yeah, that's fine. The stomach it looks large, right? And it looks like there's essentially a large air fluid level in the stomach. You would probably need a little bit more views. I can't tell if that's a massive lesion in the stomach wall or that is fluid. Or yeah, or maybe there's I would probably have to scroll to be able to really yeah, my scans of my ability to read CT scans, but I agree with you. The stomach looks very abnormal. I can't tell if that's spleen and then the stomach behind it, or that's an abnormal stomach. I also can't tell if that's solid or liquid, but the contours look very solidy. So yeah, I'd be really, really curious what uh what you all thought of the CT scan. It's definitely weird, like Deborah said.
Well, I can give you the read then. It was read as a large infiltrative mass arising from the lesser curvature of the stomach, measuring up to 15.3 centimeters in maximal dimension, that invades a portion of the left hepatic lobe, spleen, and pancreas. There is also peritoneal metastatic disease.
Oh yeah. Wow. Humbling. Deborah, what are you thinking?
nothing. I would definitely be worried. It's a really young patient and with a metastatic disease. And like, sorry, I'm trying to think. Yeah, definitely like try to investigate more.
Yeah, you seem to have some doubts, and I think that you really should have a lot of interesting thoughts. Why would you explain your hesitance here? What part of this is not adding up or making sense?
No, I'm trying to think like about this gastric mass. Like I know like gastric cancer is not something that we see all the time. So I was trying to think what could be causing, and maybe like she has like some family history. So
Yeah.
maybe try to do a biopsy to investigate more and see the type of the cancer and what could be.
Yeah, I think it's so, I mean, if you just go back and be authentic about what the pretest probability of a young, otherwise healthy woman who has a normal BMI, who has 2 weeks of postprandial symptoms, and to say, oh my gosh, this patient has metastatic cancer, that would be it's a very weird match. So I think vocalizing that is really, really important because you have to say, well, okay, the radiologist is saying there's a concern for pancreatic cancer, but I'm looking at a patient who looks well and fine. I think that can tell you potentially cast doubt on this diagnosis and maybe wonder what this is. But also, I think it can be very, very humbling as to how quickly somebody can develop such a malignant process. But then when you think, oh my gosh, this happened very quickly, could it have happened very quickly? And I think something this large is almost impossible to have developed this abruptly. Um, so I think we have to start saying, what is our differential diagnosis for a gastric mass? And I think, as you said early on, cancer looms large, and that's the thing we worried about with gastric adenocarcinoma and a lymphoma being the things that you mentioned. There's also this entity called the GIST tumor, a gastrointestinal stromal tumor, which happens most commonly in the stomach. The argument for the GIST tumor is the size. It's usually very, very large, and it's usually in the stomach. The counter argument against a GIST tumor is it very rarely, but it can spread. And so the presence of peritoneal disease here is an argument against a GIST tumor. So I think we probably have to reformulate this case and say, you know what? It was weird that she was having episodic pain with pancreatitis. And so I think now we probably have to dismiss the lipase and say she's having postprandial pain because she's putting food on this massive gastric mass, and now we know what her pain is from. And so this case really distills down to this large gastric mass, and you have to wonder, why does she have it? And I think anything from malignancy to infection to even potentially a Bezor or an inhaled or a swallowed foreign material are all very possible. What do you think would be the most helpful next step, Deborah? What would you want to do next?
Good question. I would definitely consult GI
Yeah.
and ask about it, and maybe do like some PET scan to see if the patient has any more metastatic,
Yeah.
and yeah, maybe a biopsy
Yeah.
to check what type of cancer.
Agreed. Yeah, I completely agree. I think visualizing an endoscopy with biopsy is probably the most important thing. Yeah, I would be very, very curious. I think we have to keep the patient in mind. If this were a patient who was cachectic and frail, we would all be thinking gastric adenocarcinoma or lymphoma. But the fact that she appears so well really has me hoping this is a GIST tumor. The GIST tumors are interesting. They have a nice association with liquid tumors. We've actually had a case of a patient with a GIST tumor who had another liquid tumor. I forget what that was. So the CLL of the parents may be relevant here and maybe something to explore. But what a good. I'm so glad you wanted the CT scan and you explained to the patient why. It was very, very important here. Ryan, I'm really curious. I don't know if you were involved in the care of the patient at this time, but I'm curious how you felt when you were like, whoa, she looks well nourished and fine, and I have this CT scan. How were you reconciling that in the moment?
Yeah, it was certainly surprising, and for context too, by the time we were called for admission, she had already had this CT scan done.
Yeah.
So it was, I think a lot of thinking of like how to put this all
Yeah.
together, but it was definitely a surprise.
Gosh, you have us on the edge of our seats with such an incredible presentation. I'm really curious what you have next. Oh, and by the way, I think
Yeah,
Julia, maybe I'll just tell Julia, I think Ryan took over your screen, so you might have to reshare it again, Julia. Alrighty, Ryan, we're ready whenever you are.
Perfect. So for the for the fifth aliquot, we had started the patient on IV pantoprazole, IVF, and then quadruple therapy to also treat her diagnosis of H. pylori. GI was consulted, and 2 days into her admission, she underwent an upper endoscopy, which showed a malignant appearing tumor invading into and arising from the cardia of the stomach. Biopsies were taken there. She also had a mass that was found in the cardia of the stomach and in the lesser curve of the stomach on EUS, where biopsies were also obtained. The duodenal bulb and the second portion of the duodenum were normal. And then the next aliquot will reveal the diagnosis.
Oy, oy, oy. What do you think, Deborah?
No, actually, I was thinking like they start treating for the H. pylori, like if that I don't know. I see the H. pylori maybe at this point with all this cancer and everything, like I don't know, the cherry of the cake. So yeah, what was like that would improve the patient, like would help like treating. I was gonna ask, and I was gonna ask you, Rabih, if you are gonna treat the H. pylori at this point.
Yeah, I think that whenever you have such a sinister process in the stomach, the patients should get treatment for H. pylori for sure. So yeah, I probably would. I think the question of what this mass is thankfully whenever a disease is nice enough to coalesce into a mass, you can biopsy it, look at it, and see what it is. And many times we don't have that luxury, so we have to figure it out in other ways. I think it's really, really interesting to study how bad this looks to us versus how it's impacting the patient. And I think that in all comers, you have to worry that this is gastric adenocarcinoma, so the patient will get more treatment than just H. pylori. But because of the H. pylori, I think you would have to worry that this is maltoma for sure. But I'm really, really curious to be open to the possibility that this is actually a GIST tumor, because of just how large it is and how locally invasive it is. And so I'm hopeful for the patient's sake that this is not adenocarcinoma or lymphoma. In most patients, you don't even entertain the possibility of GIST because you can see how frail and sick the patient is. And you can see how widely metastatic this is. But if you look at the pattern of the spread, this GIST tumor seems to be going from the stomach. This tumor seems to be going from the stomach and out. It's going into the left lobe of the liver. It's going to the spleen, and it's going to the peritoneum. So it seems to be spreading it seems to be spreading not hematogenously, but it seems to be spreading contiguously. So that too gives me hope that this might be a GIST tumor for the patient's sake. So to summarize, the vast majority of gastric masses are adenocarcinoma, rarely lymphoma. Lymphoma is a consideration only in patients who have H. pylori. Sometimes you can get metastatic disease to the stomach. Melanoma is notoriously does it, as does renal cell carcinoma. But here, the size and the propensity for local spread, along with the relative well appearance of the patient, has me really, really hoping that this is not those things and that this is a GIST. Any other thoughts that came to your mind or things you want to add, Deborah, before we learn from Ryan?
No, I just want to know the diagnosis. I'm curious.
Ryan, the mic is yours, my friend.
Okay, so the final diagnosis, so the biopsy was positive for a large population of large monoclonal B lymphocytes expressing CD10, 19, and 20, and lambda light chains, which is most consistent with high-grade B-cell lymphoma of the germinal center subtype, which we had, the similar thoughts as you, and hoping that this was something more benign, and it didn't turn out to be that. It ended up being large B-cell lymphoma. So the patient was started on DAR EPOCH, as well as intrathecal methotrexate. And currently right now she's into her 5th cycle of that.
Wow, Ryan, a very, very tragic diagnosis for a young, otherwise healthy person. I'm curious, what were your learning reflections? What was this a case like for you?
Yeah, I think this definitely I think makes me think of kind of the conversation that we were having earlier about an atypical presentation of something like pancreatitis, and when it really doesn't fit our typical illness script, really thinking outside of the more common causes or etiologies that we would typically attribute to, and searching not necessarily for a zebra, but for something that might, explain this atypical presentation. And so I think when now I have patients that are coming in with epigastric pain, I ask a lot more of those questions, like, is it, is there the patient pain-free in between meals, or how long has this been going on? Is that really classic for acute pancreatitis, or does this sound like something else? And we're seeing a manifestation of a more insidious process.
Yeah, I think those are very, very wise reflections. Yeah, I think that clearly there was something a lot more serious here, and Deborah had that instinct from the very beginning. What did you learn about the lymphoma here, and any pearls you want to pass on about the H. pylori and the lymphoma that you got to reflect on?
Yeah, absolutely. So I in medical school, and I think many of us have learned about the association of malt lymphoma with H. pylori. And so with that mass, despite being as large as it was, I think my money would have been on this being a malt lymphoma. But there is actually an association of a large B cell lymphoma with H. pylori after all, and improvement with treatment for H. pylori too. What I didn't share was that her biopsy was also negative for H. pylori. So I'm not sure if that's because we had already started her on quadruple therapy or not, but she did finish treatment for that. And like I said, she's otherwise, doing well. That being said, I think, just expanding our differential of gastric masses, especially in her unique clinical context too.
Yeah, I think what a humbling lesson and how something so scary can be living underneath such a benign, relatively benign concern, and to learn what the clues were of that all along. And I thought this was a really, really educational experience. I really appreciate you taking time out of your day to share it with us. It was very, very humbling. What about you, Deborah? What are your thoughts?
Yeah, thank you so much, Ryan. I learned a lot. It was a really nice case. We start like thinking postprandial and pancreatitis, and here we are. So happy to be here and always here to learn more. So thank you for helping me and discussing with me.
How does it feel doing it now compared to before? I'm curious, what has changed for you over the
Feels good. Like we start feeling more confident, but I'm studying for the steps, so I'm learning like I see postprandial. I'm like, okay, this is superior mesenteric artery, something like I just go directly for the points. It's a lot of U world, but it's
Yeah.
good.
Yeah, you world and real life are not, not overlapping, but you have to do what you have to do. Amazing. Well, thank you so much, Ryan, for such an amazing case, and Deborah for discussing. I'll pass the mic to our coffee drinker, Sohail, for the for the teaching one.
Thank you so much, Ryan, for the case. Very great, humbling again, once again, teaching lesson for us. And then Deborah, great job on the case discussion. So I don't have that many teaching points, but I'll sort of summarize these for the case. So the first thing is that the patient presented with postprandial epigastric pain, and so we should clarify if this is really postprandial pain or not. And postprandial pain, strictly defined, is pain after eating and vanishes when not eating. True postprandial pain would rule out ectopic pregnancy, as well as some of the most common causes of acute abdomen, such as perforation or obstruction. And when we think of postprandial pain, strictly speaking, we would think about gallbladder, stomach, and the pancreas pathology, especially in this patient who had pain radiating to the back. We have a high suspicion for pancreatic etiologies. The next teaching point is whenever pain is triggered by something such as exertion, such as an angina or eating, there's really no fingerprint when no trigger is present. And so this patient who had tachycardia should really keep our suspicion high for non-trigger induced pain. And so we should really question whether this pain was actually postprandial or not. The third teaching point is we then found out that the patient had H. pylori urea test, which was positive. Most patients with H. pylori are asymptomatic, although it's associated with two cancers, malt lymphoma and the GI adenocarcinoma. The patient also had decreased bowel movements, but which is most probably noise in most patients, but then there's a concern for a space-occupying lesion due to the gastrocolic reflux. Patient then, we found out, had elevated lipase, which can be falsely elevated, or rather, elevated lipase most commonly makes us think of pancreatitis, but it can be falsely elevated in the 2Ks, so the urine ketones and the kidney injury. But the 2-week time course for this patient is not consistent with pancreatitis. When we think of pancreatitis, the most common causes, think of the two S's, which is substance, most commonly alcohol or structural, gallstone or mass. The diagnosis for pancreatitis, we need two of the three diagnostic criteria, and this patient had epigastric back pain and positive lipase. So meets criteria, but we should get the CT scan for to further assess for the etiology and the consequences of pancreatitis. Management includes fluids in the first 24 hours and gradual introduction of diet and pain control, and the patient should be kept NPO initially. We then found out, or we first pondered the possibility of a malignancy when we found out on the CT scan the large infiltrative mass. GI adenocarcinoma is the most common, followed by mouth lymphoma, which is present in or commonly associated with H. pylori infections, and then GIST. We thought of GIST because of the patient's large size tumor. GIST is usually locally invasive and not hematogenous spread, and the patient was well appearing on physical exam. So we initially thought that this might have been GIST, and also for the patient's sake as well. We found out, surprise, in the final diagnosis that this patient actually had a high-grade large B-cell lymphoma, which is also associated with H. pylori, just as mouth lymphoma is. And those are my teaching points. Thank you so much for the excellent case and the learning here.
So crystal clear as always, and so well delivered. Thank you so much, Sohail. Really appreciate you, Ryan, for such an awesome case. I hope that Chief here will give you the time and bandwidth to hang out with us more often if you're able to, and teach us more with your awesome cases. And as always, Deborah, thank you for an awesome hour. Bye, guys.
Thanks so much for having me.
Thank you, Ryan.
Thanks, everybody.